Welcome back to the Checkup Podcast by Medcast. This podcast was produced in the lands of the Gundungurra people. Today's podcast is brought to you by Healthy Male.
Hi, and welcome to Medcast's Healthy Male podcast about managing prostate cancer in general practice. I'm Dr. Justin Coleman. I am a general practitioner. I work in Brisbane in Aboriginal health and have spent some time in remote Aboriginal communities over my career. And I'm very happy to introduce in this podcast a very much an expert in the area, and Associate Professor Jeremy Grummett. Jeremy is Deputy Director of Urology at the Alfred in Melbourne, and he's also been on the working group to formulate the new PSA testing guidelines. Welcome, Jeremy.
Thanks, Justin. It's great to have an opportunity to chat about this.
Plenty to talk about, but we'll talk about something which is probably close to your and my heart, which is the role of PSA testing in the population. And I know for GPs, we do struggle with this. There are conflicting guidelines and the evidence changes over time. Certainly, historically, there is a tendency of Australian GPs to order considerably more PSA tests than our counterparts overseas. But you've been part of the old guidelines and a part of reconstructing the new ones. Yeah, what's new in the space of PSA testing?
Yeah, thanks. So I guess just to set the scene, we've had NH and MRC guidelines on PSA testing since about 8 years now. And so an enormous amount has changed in that time and changed for the better, which I think is exciting. So our role now, amongst various other stakeholders, is to create an updated set of guidelines that reflects all the evidence that's come on board in that period of time to help us better work out how to perform PSA testing for prostate cancer.
I mean, a summary of the current guidelines, as you say, written now some time ago, would be that GPs aren't advised to actively seek out PSA screening, although there are, of course, circumstances you would do that, and also there's patient preferences and things. And it's interesting that advances in treating prostate cancer won't change that sort of prospect because screening is no more useful if treatments get better. But the advances, which we'll talk about a little bit now, in minimising the harms of men who do have positive PSA tests, I think that's where the real change is going to tip the balance.
Yeah, you're absolutely right. And that's exactly what's happened in the last 8 years is there have been various factors, and it'd be worth touching on them as we go through our chat, which have really reduced harm or the risk of harm that can otherwise occur as a result of PSA testing. Now, in doing a PSA test, we're obviously the whole point is to try to find prostate cancer that is of an aggressive nature that may have implications either for the patient's health or life expectancy. But we do not want to be causing them harm. And the problem and the reason there's been so much controversy about PSA testing up until now, or certainly previously, is because there has been harm caused by PSA testing. And in fact, there will always be some risk of harm in any sort of early testing program, really for any disease. It's a matter of how do we minimise that and make it worthwhile so that the harm doesn't outweigh the benefit. And I think that's the critical changes. So just to give you an example, there are really three aspects. Probably the two biggest game changers in harm minimisation in this space have been the introduction of routine imaging for prostate cancer in the form of a prostate MRI. And the other big thing, which I'm sure most GPs will be very familiar with, is the concept of active surveillance of low-grade prostate cancer. And that's become far more widely accepted. In the bad old days of more than a decade ago, far too many men were getting treatment for prostate cancer that was really in retrospect, unnecessary. And everyone knows that treatment of prostate cancer, the treatment itself can be quite harmful in terms of causing nasty side effects which can really impact men's quality of life. And, the obvious ones are erectile dysfunction and sometimes incontinence of urine. If radiotherapy is the treatment, then you can also have symptoms related to bowel function due to radiation injury of the rectum. So there's a lot of harm that can potentially be done. We've really got to figure out which patients actually need treatment.
Well, Jeremy Grummett, let me take you through a patient journey then. So you got the fella comes in and he's got a high PSA. Now, when we say a positive PSA test, what's important to remember there in terms of what we test and what numbers we're looking at?
Yeah, so a positive test currently is considered greater than 3.0. Now, if we want to drill into the details, you can alter that depending on the patient's age, but I think for GP purposes, as a starting point, if you just think of a PSA of 3 or up to 3 being normal, that's very helpful. But as everyone knows also, there's a lot of fluctuation, even within the same individual over time of one's PSA. We don't always know exactly why that is. There are various theories. There may be, for example, altering states of inflammation of the prostate, which might release more PSA into the bloodstream periodically. Regardless of the reason, it just is really important to repeat a PSA to see if the original one is sustained or possibly even higher in some circumstances. And the other aspect to that is what's the time interval that ideally that we should use for repeating PSAs? And the answer to that is twofold. One is clinical and the other is pragmatic. First of all, the answer is we want to repeat a PSA between 1 and 3 months after an initial elevated PSA, okay? So if the first PSA is abnormal, repeat it in 1 to 3 months. The idea is that if there was perhaps an inflammatory process that was going on, that gives it enough time to settle down and the PSA might normalise. And that's great because then you don't have to proceed with any further investigation. On the other hand, if it's elevated, then you're more likely to be dealing with something more suspicious of cancer. Plus, the next step after that is to order a prostate MRI. Now, the prostate MRI in Australia has been covered by Medicare for the last 4 years now, but there are quite strict criteria about that Medicare reimbursement, one of which is it needs to be ordered by a specialist. Now, that's almost always a urologist because we're the ones who tend to actually diagnose the disease.
Yeah.
And the second part is that it has to be in those two PSAs do have to be between 1 and 3 months apart.
In terms of accessing an MRI, what are the caveats there and what sort of findings are we expecting to look for?
As I say, that'll be ordered by a urologist typically. So in other words, a GP will have made a referral based on those two elevated PSAs. Very likely that the urologist will then order a prostate MRI and with experience will be aware of where to order the prostate MRI because it's quite a subspecialised scan. It's not as straightforward as, say, a hip or a knee MRI. And so the machines have got to be calibrated appropriately for prostate MRI, and you've got to have radiologists who are experienced in reading what can be quite complex and nuanced scans. So urologists will make that referral, the MRI will get done. And then in terms of what the results might show, and this is one of the huge advantages of MRI, is that it basically will only show up the more aggressive types of prostate cancer. So MRI, very rarely can you actually see the low-grade indolent prostate cancers, which we really don't need or want to find because they're the ones that can lead to overdiagnosis and overtreatment. So when the MRI is positive and it does show a lesion suspicious of cancer, we're talking about a clinically significant cancer, one that does have the potential to metastasize.
Yeah, that's really interesting. In fact, it's ideal having a test, isn't it, that isn't super sensitive. In other words, it's only sensitive enough to pick up things that really will make a difference. And I certainly remember when, the more sensitive troponins came in emergency departments, a lot of us were thrown because you can get a rise in troponin, after running 15 kilometres sort of thing, and it was almost too sensitive for their own good. So it's quite handy in that sense that the MRI has that threshold that is above the indolent cancer that you have no benefit in treating.
Exactly. It's absolutely ideal. And it just means that we use MRI, therefore, as a mechanism, a very powerful mechanism to then triage which patients to biopsy. Now, obviously, biopsy is an invasive procedure, albeit minor. It's still invasive. And in the past, a couple of elevated PSAs would have led directly to an invasive biopsy. Nowadays, MRI intervenes, and if the MRI is clear, there is no biopsy. All we need to do in that case is check the PSA down the track, which is obviously a simple blood test. We don't need to perform an invasive biopsy. So the evidence in the literature is telling us that we can reduce the rate of biopsies, unnecessary biopsies, by 30%. So only 2/3 now of men are getting biopsies that would have otherwise gone straight to them, which is a huge benefit.
Looking again at thresholds, a lot of medicine is all about, when do we pass the threshold to do something versus not do something. So how do you then divide those men based on their findings into those who need more active treatment and those who you can watch and wait? What are the criteria?
Just one other thing that really is worth mentioning is that the biopsy technique for prostate has now changed enormously as well. We used to routinely perform a prostate biopsy via the rectum, and although that was quick and easy perhaps for the doctor, it was pretty ordinary experience for the patient, including a significant, albeit small, but significant risk of sepsis by passing bacteria from the rectum into the prostate gland. We now perform transperineal biopsy, that is via the perineal skin, which is very easy to disinfect with typical surgical prep. And our risk of sepsis with that technique is either zero or near zero. And that's been a huge advance again, whereas biopsy sepsis was all too common in the old days. We basically never see it anymore. So that's another risk reduction that's taken place.
Great.
But in terms of pathology outcomes of the actual tissue, occasionally, even if the MRI is suspicious, occasionally we'll still find that the biopsy is negative, that is, the tissue is benign. It's not common, but no test is perfect. Occasionally we will detect low-grade prostate cancer, which many GPs will be familiar with, Gleason 6.
Yeah.
Now, Gleason 6 is actually a way of grading that we are trying to phase out because in terms of the Gleason system, I should say, because it is confusing for patients. Gleason 6, bear in mind, is the lowest cancer you can get in prostate, and it's pretty odd for patients that a range that starts with 6 is actually the lowest.
Yeah, it's a bit like the Glasgow Coma scale. You can be dead and still have a score of 3. Yeah.
Exactly. And so it's a good analogy. So we are moving to what's called the grade group system, which is grades 1 to 5, whereby Gleason 6 equals grade 1. And of course, the biopsy might show anything above grade 1. And if it is above grade 1, so grade 2, 3, 4, 5. So, for example, the old Gleason 7 is actually divided into grade group 2 or grade group 3. And once you go into those grades, you do have what we would call clinically significant cancer, because there will be a component of the tissue not all of it, but some of the cancer tissue which has aggressive features. And we know that those aggressive features have the potential, by no means the certainty, but the potential to metastasize. And so they're the ones that do put men at legitimate risk of harm.
So the man I'm talking about has gone through all that and had their biopsy, and you have to decide whether to treat now or to survey. So what does it mean for him if he's going to go into the surveillance group?
So for the low-grade cancers, which is grade 1, as I mentioned, or Gleason 6, and some of the men in grade 2 may well be appropriate for surveillance as well. What it means is that we, as urologists, in combination with GPs, will measure their PSA on a regular basis. Initially, it might be 3 months, but if the PSA remains relatively stable, that would quickly push out to 6 months, and we would monitor it that way. Now, down the track, again, depending on other factors, we would likely repeat an MRI to make sure that whatever was seen previously hasn't changed. But we wouldn't do that within the first 12 months. We're not. Yep. If it's low-grade disease, we're not going to see any significant change in the first 12 months. So it would be over a greater period of time than that. We may also repeat a biopsy. Again, we want to keep invasiveness to an absolute minimum, and MRI is helping us to do that enormously. However, we may need to repeat a biopsy again down the track. It might be anywhere between 1 and 3 years after the initial biopsy. And certainly, if PSA is rising, then that will trigger an earlier scan and or biopsy.
Okay, so the person being surveyed may remain surveyed for life and nothing happened, but often enough, I guess at some point in time, the PSA will rise. They'll have this either biopsy, but possibly both the MRI and subsequent biopsy, and then move into the treatment group.
Yeah, so that would happen, for example, if there was a rising PSA, let's say an MRI was done which showed that the lesion had perhaps increased, and so a repeat biopsy was performed, and what was, for example, grade 1 disease has actually upgraded to perhaps grade 2 or 3. A conversation with the patient would ensue then about the increase in risk to metastatic disease and advice about the pros and cons of then having curative treatment rather than maintaining the patient on active surveillance.
And I think over the years, with conversations with men and men's articles and men's health groups and things, there has been a more general understanding among men that you can have this sort of indolent, somewhat raised prostate, maybe a low-grade cancer, and it's not necessarily going to be a death sentence. But certainly, as GPs, a proportion of that group are going to get pretty nervous and anxious about it. And I think it's good for us to remember there's a level of reassurance required. Are there any particular services which help us out in that regard?
There are prostate cancer nurses, which are around Australia, which are basically being provided and funded by PCFA. Who can be very helpful in this space. There are men's groups dotted around the country as well. And I guess from my perspective as a urologist, there are GPs, who are interested in this space themselves who can help us reassure the patients. But in terms of that anxiety of men on active surveillance, I think one of the most powerful things is the advice they get from their doctors, both GPs and their specialists, to say, for example, if it's grade group 1 disease or Gleason 6, it is safe. It is standard of care, in fact, to be monitored rather than actively treated.
Thank you. I'm talking with Associate Professor Jeremy Grummett, and we might finish a little bit with the future. So In terms of treatments, perhaps if you could just very briefly outline the treatments which most GPs will be aware of those groupings, and then finish off with if any of those have substantially changed or likely to change over the last couple of years.
Sure. Thanks, Justin. So I'm sure everyone will be familiar with the current treatments. And of course, we're talking about localised disease here. So we're talking about treatment with curative intent. And the two standards are surgery, that is radical prostatectomy, or radiotherapy, either in the form of brachytherapy, which is seed implantation, or external beam radiotherapy. Just as there are two options within radiotherapy, of course, you'll be familiar with in surgery, you can either do it via an open approach or with keyhole, and nowadays certainly the keyhole approach is almost always done with the help of a robot. So they're the two standard treatment options. And as I said earlier on, both of them come with the risk of significant side effects, and that's despite advances within those technologies. When we're doing robotic surgery, for example, we can be very precise about dissecting off the erectile nerves from the prostate to maximise the patient's chance of maintaining erectile function. Similarly, in radiotherapy, there are technologies that have improved the radiation dose to better fit the shape of the prostate and minimise dose to surrounding structures. But even then, patients still have a significant risk of those side effects we talked about. So I think one of the most exciting things, and again, this comes under the banner of risk minimisation once again to men undergoing PSA testing, is that on the one hand, we've talked about active surveillance at one extreme, in other words, not treating but monitoring closely. On the other hand, we've talked about whole gland treatment, whether it's radiation or surgery. And what we're seeing now is the emergence of an option that sits right in the middle of those two, and that's called focal therapy. And there's a lot of study being done, not only in Australia but around the world in this space right now. And it makes perfect sense because we've been talking about how MRI has had a huge impact on prostate cancer diagnosis. Well, the corollary to that is that it can have a huge impact on treatment, because for the first time, we've been able to actually see where in the prostate exactly the cancer is. And that's great for diagnosis because we can then pinpoint the biopsy, make sure we get the correct diagnosis. But as you can then imagine, the logical next step is, well, why don't we use that information for highly targeted treatment? And so we can do that where we can kill the cancer cells of the prostate cancer without affecting the surrounding tissue, let alone the normal prostate tissue in the rest of the prostate gland. Now, there are various ways of doing that. There are different modalities or energy sources that we can use. One of the things that our group has been exploring is brachytherapy performed focally, but there are other modalities such as irreversible electroporation, otherwise known as nanoknife or IRE. Some people are using laser, some people are using HIFU, some people cryotherapy. It doesn't really matter at this stage as long as the tissue, cancerous tissue, obviously gets ablated or destroyed. And so there's much interest in this field at the moment and a lot of excitement because the early results, at least, from a functional point of view, are outstanding, where there is a genuine reduction in side effects compared to radical treatment. What we're waiting for, and these will emerge over the next few years, are the actual cancer outcomes. Do patients actually do better, or as well as? They don't have to do better. They just need to do as well as the radical treatments with a reduction in side effects for them to become a mainstream option. So I would just say watch this space. It's certainly not standard of care right now because we don't have the long-term data, but it's not far away.
Look, that really is a good positive note to end on. And I think, if we'd done this podcast even, say, 5 years ago, we could probably have said that not much has changed in the last, 20 years. But I do think there's enough out there now that I am really feeling quite positive about the future, because, of course, it's a huge thing for keeping males healthy, and up until now there've been relatively limited pathways to go down. I suspect as with all emerging technologies, some will be touted as the next big thing and fade away a bit, but certainly there's enough out there that you would think some of them are going to break through and become standard treatments over the next decade or so. Jeremy Grummett, it's been a delight talking to you. Thank you. And I think the listeners will be very happy with your description of things and the fact that newer things are on the horizon. So thanks for coming on today.
That's been an absolute pleasure, Justin. And hopefully our discussion's been really useful for our listeners. Thank you.
For more information on this topic, including supporting notes and on-demand webinar content, search for Healthy Male on the Medcast website.